Hi, this is Patrick Aaron Devillo from Pamantasan ng Lungsod ng Maynila. I am here to show you how to manage clients using an electronic medical record. So what are we waiting for? Let's do a hack.
Sorry, it's DJ.
With this video, we're going to use OpenMRS, a global leader in open technologies and open standards in healthcare. I'm going to use their demo by going directly to openmrs.org/demo. As you can see and read, OpenMRS demos are designed to give you a taste of OpenMRS from an implementer's point of view. It is a fully working copy of OpenMRS with observations on large numbers of anonymized patients. Remember, these are not real patients. So before we launch the demo, I'm going to present to you first the case I have chosen to record. So a 70-year-old man was taken to the hospital by his daughter, who stated that her father was weak, vomited 4 times, and has pain in his belly. She also informed that his appetite is poor and he is very anxious. On assessment of the client, he is lethargic, states his pain is a 9 on a scale of 1 to 10. He vomited 3 times, 100 milliliters of greenish fluid, and passed approximately 150 milliliters of urine in the urinal. His temperature is 102, pulse 80, respiration 22, and blood pressure 140/80. So now let's use the OpenMRS to record those information. Click on Launch the OpenMRS demo and you will be routed to their login page. Enter the username and password. Importance of username and password is data privacy. Different logins mean different patient records to access. And for the session, we're going to use inpatient. After logging in, register your patient. So our sample patient for today is Juan Cosayo. He is a male, 70 years old, haven't gotten his birthday though. Enter his address, then his phone number. He is accompanied by his daughter, then recheck all details and click confirm if everything is already correct. Now, because I have not input the birthday of the patient, the system automatically inserted the first day of 1966, which is probably the year when the client was born. As you can see, Mr. Juan Cosayo now has a patient ID. On the left corner, you can see all the details entered about the patient. It is still left blank because we have not yet input anything. On the right, you can see some access icons. For this part, we are first going to start a visit. Then admit to inpatient. Let's assume he was admitted today by Dr. John Smith and his ward, inpatient. Now we have to do the most common thing nurses do, taking vital signs. Let's say the patient's height is 180 centimeters with a weight of 70 kilograms. Then the BMI will be automatically computed by the system, so you don't need to do math anymore. Then his temperature, 37 degrees Celsius. Pulse is 80, meaning normal. RR is 22, perfectly fine. BP 140/80, considered normal based on his age of 70. Oxygen saturation is 95, normal. After capturing the vitals, click on Visit Note to fill out details about the visit of the patient. Again, doctor is John Smith. His presumed diagnosis is bacterial foodborne intoxication. On the clinical note, utilizing a SOPI or SOPI charting is recommended because the patient's nursing record provides a correct account of the treatment and care given and allows for good communication between colleagues. And keeping good nursing records also allows us to identify problems that have arisen and the action taken to rectify them. Let's input all our subjective and objective cues, making sure that we only input all necessary information in a brief manner. So subjective data, daughter states that her father was weak, vomited 4 times, and has pain in his belly. She also informed that his appetite is poor and he is very anxious. Patient rates pain 9 on 1 to 10 scale. Objective data, a 70-year-old man was taken to the hospital by his daughter. On assessment of the client, he is lethargic. He vomited 3 times, 100 milliliters of greenish fluid, and passed approximately 100 milliliters of urine in the urinal. His temperature is 102, pulse 80, respiration 22, and blood pressure 140/80. Then our nursing diagnosis. Risk for deficient fluid volume related to vomiting as evidenced by patient vomiting 3 times 100 ml of greenish fluid and report of poor appetite. Also, another nursing diagnosis is acute pain related to vomiting secondary to vascular dilatation and hyperperistalsis as evidenced by patient rating pain 9 on 1 to 10 scale and active vomiting. If you are not that familiar with some other nursing diagnosis, be sure to check out Nanda Book PDF on Google and you will see 11th edition Nanda International Nursing Diagnosis where you can see all possible nursing diagnosis arranged in a logical manner together with its definition, risk factors, and associated conditions, all for free. Now we can formulate the interventions and expected outcomes. For these, we can of course utilize the internet to search for some information, may it be a medical dictionary, pharmacy information, or just a simple inquiry. However, we still need to validate if those information we retrieved are reliable. Here is the criteria I use to evaluate websites. What is the URL? Who is the author or who are the authors? Are author credentials provided? If so, what are they? Are citations and references provided? If so, So, what type of references were used? Is the material biased? If so, describe how it is biased. What is the parent institution? What is the domain type? Who is the intended audience? Are there grammar or spelling mistakes? When was the website last updated? Are there links to other websites or resources? What are they? Is this a website provided by the library? Was it a website found through a search engine like Google? After evaluating the website, making sure that the health information gathered is appropriate to the client needs is easy as switching tabs, as you can already see and compare them on the electronic medical record provided in the OpenMRS. Let's now note our interventions and expected outcomes. So for nursing interventions, regularly monitor and document vital signs, especially blood pressure and heart rate. Reason for that is decrease in circulating blood volume can cause hypotension and tachycardia. Alteration in heart rate is a compensatory mechanism to maintain cardiac output. Usually the pulse is weak and may be irregular if electrolyte imbalance occurs. Hypotension is evident in hypovolemia. Next is to assess the color and amount of urine. Report urine output less than 30 ml per hour for 2 consecutive hours. Reason for that is a normal urine output is considered normal, not less than 30 ml per hour. Concentrated urine denotes fluid deficit. Next is to monitor fluid status in relation to dietary intake every 12 hours. Because most fluid comes into the body through drinking, water in food, and water formed by oxidation of foods. Verifying if the patient is on a fluid restraint is also necessary. Next is to monitor serum electrolytes and urine osmolality and report abnormal values. Reason for that is elevated blood urea nitrogen suggests fluid deficit. Urine-specific gravity is likewise increased. Next is to assess alteration in mentation or sensorium every 2 hours, because it may be caused by abnormally high or low glucose, electrolyte abnormalities, acidosis, decreased cerebral perfusion, or developing hypoxia. Impaired consciousness can predispose patient to aspiration regardless of the cause. Also, assess skin turgor and oral mucous membranes for signs of dehydration, because signs of dehydration can also be detected through the skin. Skin of elderly patients loses elasticity, hence skin turgor should be assessed over the sternum or on the inner thighs. Longitudinal furrows may be noted along the tongue. Urge the patient to drink prescribed amount of fluid by the physician, because oral fluid replacement is indicated for mild fluid deficit and is a cost-effective method for replacement treatment. Older patients have a decreased sense of thirst and may need ongoing reminders to drink. Also, emphasize importance of oral hygiene, as fluid deficit can cause a dry, sticky mouth, and attention to mouth care promotes interest in drinking and reduces discomfort of dry mucous membranes. Also, you need to help the patient plan daily activities, as planning conserves the patient's energy. Okay, now for the acute pain diagnosis. The nurse should assess patient's pain rating every 4 hours. We also need to administer 1 milligram IV morphine every 4 hours as needed for pain greater than 6 on 1 to 10 scale if ordered by the physician. And we also need to assess the patient energy level every shift. Alright, after the care, these are the expected outcomes from the patient. Patient's urinary output will maintain at least 30 cc per hour. Patient will be able to tolerate clear liquids without vomiting within 24 hours. Patient will have equal intake and output within 24 hours. Patient's electrolyte levels will remain within normal range throughout hospital stay. Patient will rate pain less than 3 on 1 to 10 scale within 6 hours. Patient will report feeling less lethargic within 48 hours. After completing the clinical note, you will be routed back home where you can see all the patient's details. Here you can input a condition, attachment, allergy if there is any. All these information are needed to make sure that the nursing care plan that we did is individualized to the patient's needs. If the patient has already recovered, you can include discharge planning on the clinical notes once again for documentation. So now that we're done, let's talk about advantages of using electronic medical records in healthcare like what we did on this video. Obviously, they are better than paper records. First reason is that papers take up space physically, while even thousands of EMRs can be stored in a single cloud server that you can also back up to be more secure. Plus, you don't have to search for patient files in a physical cabinet, because the software does that for you instantly. Is you just need to type everything rather than writing with a pen. Obviously, writing isn't always legible and therefore can be hard to interpret. Also, while paper-based records can be easier to customize, it also means that the layout and format of information can be inconsistent from one record to the next. Electronic records, however, have a consistent format which healthcare providers can get accustomed to. Paper records don't have built-in version histories and audit trails. EMR does have. knowing who made which edits and additions easily entails accountability of the care provider and saves the time of the provider because he does not need to put signature on every note he does. Most importantly, it improves the workflow on healthcare settings. For scheduling appointments sought from the Integrated Patient Health Record Portal may reduce phone calls and missed appointments, especially if there is an automated appointment reminder email sent both to the patient and care provider. As appointments are stored online, physicians can check their schedules from their devices. For the front desk and the nurse office, it helps in documentation and information dissemination. With consultations, doctors using EMRs can process an electronic prescription and an electronic lab request for the patient. Plus, it will be easier to track changes in a client's health over time to make treatment recommendations and to share medical records with the client's other healthcare providers. For billing, it helps in managing invoices, tracking payments, and filing.
Thank you for staying with me on this video. I hope I have made you appreciate how electronic medical records do magic in the healthcare settings. Again, this is Patrick. See you again.
Sorry, it's DJ.